Evening, everyone. Thank you for joining on time. It's a pleasure to welcome you to this webinar on considering a career in medical oncology. I'm sure hopefully others will join, but we'll make a slow start so we can get to the questions and answers. If we go to the next slide, Richard, please. So we're going to work through, there's a few of us on the webinar tonight. We're going to work through some brief presentations. I'll briefly introduce everyone and people can chat as they go through their slides. And then we've got plenty of time at the end for questions and answers, and that's really your time to put into the panel any questions you've got about recruitment into oncology and how the process works. We've seen plenty of questions in advance, so thank you, and hopefully the presentations will cover quite a few of the things that are on your minds. And what's really great tonight is we've got people registered from a range of stages right through from undergraduate to those of you who'll be applying in the next rounds. So realize there might be some slightly different questions, and we're happy to try and answer those as much as we can. So, as I said, welcome. My name's Simon Pacey. I'm a medical oncology consultant at Addenbrooke's. I'm the clinical lead for national recruitment and the training program director for the East of England. And I'm joined this evening by Satinder Jagdev, who's our chair for our National Training Committee, and Richard and Ben, who are members of our Association of Cancer Physicians Committee and Specialist Registrars. And we're delighted we've got Louise Hanna with us from the Royal College of Radiologists representing clinical oncology so that we can cover both our specialities because the questions often come up that are relevant to both of us in the Q&A later on. Next slide. So we're going to run through briefly introductions, and I'm going to give you a very brief overview of the recruitment process, but it won't waste too long on that. The webinar will be recorded, and some of the information, if you want, you can go back to, so we can spend more time on perspectives of the process from Ben and Richard. Satinder's going to give you a talk of life as a consultant in medical oncology. And then, as I say, we'll move on to a panel discussion to clear up Q&A. And as Richard said, if you put questions that occur to you in the chat, we'll try and pick them up when we get to the panel discussion at the end. Thank you. Next slide. So as we move into the current round, some of the dates are yet to be confirmed, but this is broadly where we are at the moment. So job adverts for the next round should go out slightly later this month by the 19th of November, with the application window opening until 4 p.m. on the 11th of December. Our planned interviews for medical oncology are the 19th and 20th of March next year, which means the offers deadlines will be coming out around the 14th of April by 5 o'clock that evening, with a view to starting posts on or around the 5th of August 2026, depending on the posts you choose. So that's the current round dates. Thank you, Richard. The applications are similar across a lot of the Group 2 specialities. So in very broad terms, we are needing you to have completed your internal medicine training. And there's an Am I eligible section on the PRSO website. And there's a theme to what I'm going to say here, which is if you're in doubt or you want the information, please look at the PRSO website. There's a lot of information, sometimes quite a lot to read through, but various links to give you an idea of what information you need and what evidence is required. So hopefully most things should be there. You will submit your application through Oriel and you'll get emails confirming that. But one of the best things to say here is don't leave this to the last minute. It is worth knowing that that application has gone through, been received. And if you don't get that confirmation email, you can contact the PRSO the day after to make sure your application's received. You don't want to fall foul of the deadline if you've done everything else. So please get that in on time. We then move into sorry, Richard, that's fine. We're moving to a long listing stage, which is on the next slide. Thank you. So there's broadly three stages. Long listing done in the background. Do you meet the main eligibility criteria for the higher speciality post around MRCP, core capabilities, minimum experience? We haven't had to move to shortlisting, particularly for medical oncology. We try and have enough interview capacity, but we are getting increased numbers of applications, so we may have to do a shortlisting stage, but we do, as a minimum, look at commitment to speciality, and we can talk about that in a minute. as part of the process before we move on to verify submitted evidence. And if you are taken through the evidence verification and commitment to speciality, we move on to the interview with two panels of two consultant interviewers with a set of 4 questions run on a virtual interview. Thank you. Next slide. So like I said, we look at your answers to commitment to medical oncology first, and this is assessed independently with 2 assessors. The score doesn't form part of your final mark, but it is used to assess whether you move forward to further self-assessment verification and into interviews. The reason we don't use it as part of your final mark is you have a portfolio review within the interview. So this question does take account of the stage you are at in training and your career history, and it is marked recognizing that some of you will not have had the same opportunities as others. So this is the thing here is not to panic if you haven't done a medical oncology job. The commitment can still be demonstrated, and you could still score 10 if you look at the anchor statements and explain in the white text boxes how you meet those criteria. The other key thing there is to say, really think about what you write in the boxes and explain how you meet those criteria. Please don't assume that the people assessing it will know what you mean if you've spent 6 months in a particular job. Have a look at the anchor statements. Give us a chance to really understand how you're committed to a career in medical oncology. Thank you. Next slide. The rest of the evidence on the upload is again on the websites, and the most up-to-date guidance will change slightly. I don't think there are any major changes from the current round we've just gone past. But this shows you the spread of marks and what domains attract the most marks. And I think you can see here that MRCP attracts quite a lot of marks. There are good marks for publications, presentations. But have a look through the guidance, have a look at your CV, compare yourself to each domain and see where you think you can improve if you're thinking about building your application for later. It's all out there and publicly available. And it also relates to some of the questions I think you've been asking that we may come back to if you don't feel they've been answered. Thanks, Richard. Next slide. The documents that you have to upload is a separate upload system, and broadly we need to make sure that when you pick a score that there's enough evidence for someone to verify that. You have to have the guidance changed about 12 months ago, so we have to pick the score based on the evidence, not giving benefit of the doubt. So do be careful what evidence you put in. You're assessing against that scoring matrix, and then senior clinicians will have a look and verify that score up or down. That score goes forward to make a potential proportion of your final score. Again, have a really good look at the detailed guidance. Try and use the evidence in the form that we ask for. It's much easier if you're using recognized forms. And again, there are template forms that we've started using this round to make it easier to understand what evidence is required, especially if you're maybe not, some of your evidence was acquired overseas, for example. Please redact any patient identifiable data. Just be super careful that you don't have any patient information there. And bear in mind that there are marks for organisation within the score. So if your application looks disorganised, or you haven't uploaded the right evidence or kept it easy for the assessor, then that you will lose some marks for that. Thank you. Next slide. Interviews. Ben and Richard might talk about this in a little bit more detail, but I think my biggest suggestions are consider getting some practice with colleagues. Actually, it's just important to work through understanding the teams and the timings. Look out for your invitation and get your booking organised on time. And just think about the preparation, the technical aspects, that your camera's working, where it's positioned, how you can look at the camera to try and get as much sort of personal contact, even though it's a Teams call, as possible. The format is summarised there. As I said, it's 11 minutes per panel with 2 panels. We have 4 scored questions, scored from 1 to 5. The clinical question, professionalism and governance, suitability and commitment, which is the portfolio review, and an academic research question. Thank you. These are the scores. You can come back to this if you want to, but you can see that adds up to a possible raw score of 40. And again, to remind you, we're looking for midpoint CT2 for groups 2 specialities. So The score of 3 would be where we'd expect you to be at the end of that core medical training year 2, at the day of starting the job. And you've got the appointability criteria there. So if you score a 1 in any area, then you're considered not to be appointable at interview. And they're listed there, so I won't read those out. Thank you. Next slide. The offers come through on Oriel. It's done in a ranking system as with everyone else through the same physician system. The thing that's worth thinking about is the posts that are advertised. So don't be put off if your preference area might be showing 0 posts. If you preference that, the system will account for it. If you're ranking number 1, you'll get your choices in order, even if there's no post. And have a chat with the TPDs, because it may be those post numbers change. So do not assume that there's no posts if they're listed. If there's somewhere you really want to work, talk to the people in the region. Employers will run all the relevant pre-employment checks, and the posts start on the first Wednesday, in this case in August. You can have a different date, and again, contact the region. And there's lots of information on the PHST websites. So midpoint to IMT for the scoring, and do contact people in the region or from this webinar if you've got questions, whether that's the training director, current SPRs, STRs, as I say, medical, clinical oncology work closely together, all happy to discuss what the career is like. So just ask for help and advice, and best of luck with your applications. I think that's all I was going to say. So going to pass over to Ben and Richard to give you life as a medical oncology SPR. Thanks, everyone.
Yeah, thanks, Simon. So, my name is Richard Hayward. I'm a medical oncology registrar in Leeds, in Yorkshire. I'm currently the chair of the ACP trainee committee, although I'll be handing that over to some colleagues in the new year. So I'm just going to go through a little bit about my journey of how I've got here, and then a little bit about some of the differences between medical and clinical oncology, because that's a question that came up quite a lot. And a bit of general advice for applications and interviews, although Simon has already gone through some of that. Obviously, if there's any questions in the chat, feel free to add them. But I thought it'd be useful just to go through a little bit about how I got here. Everyone's journey is different, and I think that's really important to know. So sort of don't think that there's a standard one-size-fits-all way to get into medical oncology. So I started a long time ago, it feels like a long time ago now, 20 years ago, as an undergraduate. And I actually did go through a research program whilst I was at medical school. So I did an integrated MB PhD program. Now that's not usual. And we do know from our recent trainee survey that actually it is now the minority of people that have research degrees. So you certainly don't need that to be a good medical oncologist. But that's what I did. And then I went through my FY1, FY2 training, didn't do any academic jobs there. After my FY2, I did what lots of people do and went to see the sun in Australia for a year, and thoroughly enjoyed it, and would recommend that actually, as long as you come back. Obviously, I can't recommend people to stay there. So I came back and moved up to Leeds, did my core medical training here, completed PACES and MRCP. And then in 2020, I applied to medical oncology for the first time. And as you can probably tell from the timing, that was very much affected by COVID. And unfortunately, I didn't get a job in that round. So what I did is I applied to get a clinical fellow job at the Christie in Manchester, and thankfully was successful. And I spent a year there. And I think that actually stood me in much better stead for starting my training program than if I hadn't. So I applied back in 2021 and thankfully was successful this time. And since then, I've been working in Leeds as a medical oncology SPR. I'm due to finish in May next year. And as of 2022, sorry, I've actually gone down to 80% to look after my children. And I think increasingly we're seeing that lots of people are doing less than full-time training. So it really isn't a barrier to working in medical oncology. And if anyone wants to discuss less than full-time things, I'm more than happy to do so. And I passed the exam in 2023, my final ever exam, hopefully. And so now sort of preparing to make the transition to consultant. So this is just my timeline, but clearly everyone's is unique, and I think there's lots of it never goes quite in exactly the sort of way you think. And if you'd asked me in 2015 when I graduated what my career would look like, there's not a chance I would have guessed it would have gone like this. So you never know what's going to happen, but as long as you know what you want to do and what you're aiming for, then that's the main thing. So I think Simon's already touched a little bit on this, but I thought it'd be helpful from our perspective to talk a bit about the differences between medical and clinical oncology. So at the moment, they are both Group 2 specialties, as I'm sure you're aware. So you can apply at the end of your to start at the end of IMT2. Some people do choose to go through their IMT3 year, and I think there are reasons why people might do that. You don't have to, but certainly if you do your IMT3 year, you can then apply again at the end of that. And that may give you a certain skill set that you may not have otherwise got. You do have to have completed your MRCP, including PACES, and that was relaxed for a few years around COVID times. But I understand that is back now. That you do have to have passed PACES by the time you start your training. So it is really important to try and get that done as soon as you can. You don't dual train in in internal medicine, so for some people that's an attraction. I won't comment too much on that, but it means that you single specialize in medical oncology, and as part of that, there is an increased emphasis on acute oncology, so managing acute presentations of cancer and cancer-related treatment. And if you are interested in more acute things, then there are more and more consultant job plans that do include some acute oncology activity as part of that. The on-call requirements vary, so almost all centres in the UK, you do non-resident overnight on-calls. There are one or two exceptions, Christie being first and foremost of those. But generally, you don't do resident nights as a medical oncology registrar, but you do long days and weekends. So at the moment, both medical and clinical oncology trainees start on the oncology common STEM, which is the first year of their training. So that's your ST3 in either of those specialties. It's just there after you get selected into your training post. The idea here is that you do rotations in tumor sites that combine some exposure to systemic therapy, but also some exposure to radiotherapy delivery. And there's also an emphasis on just developing your generic skills in managing acute problems and acute complications of cancer. It means that we get more exposure and more training in how to deliver radiotherapy, although obviously we're not going to be doing that as consultants. And there is the potential to, if you want to choose to switch specialties, you can do so at the end of ST3, although you still have to go through the national selection. But that allows you to potentially change and not have to start all over again. So the differences between medical, as you can tell, I am less than full time and have children in the background. So medical and clinical oncology. So I think this is to highlight some of the differences, but I think it's really important to mention, and Dr. Louise Hanna is here, obviously, from a clinical oncology perspective, that there is a lot more similarity, I think, than differences. And I think the skills that make you a good medical oncologist would also make you a good clinical oncologist. And it's certainly true that the majority of people do apply to both. I don't know the numbers exactly, but I certainly applied to both, and I know a lot of people do. And I think for a lot of people, they would be happy doing either one of them. I certainly, if I hadn't been offered a medical oncology job in Leeds, I would have certainly considered a clinical oncology post. But in terms of the main differences, so one is which college you're affiliated with. That's a fairly big difference. The medical oncology training is also 1 year less, so slightly shorter training, and there are fewer exams. There's just the one exam in medical oncology, which is usually done halfway through your training. And just in the terms of the day-to-day job, the medical oncology sort of rotations, you're delivering systemic therapy to patients. You perhaps have a slightly broader range of patients in terms of where they're at in their treatment. So lots of people with palliative intent treatment, although we are increasingly giving people curative treatment. And there's also very much an emphasis on working in clinical trials in medical oncology. There are some specific tumours that I've put down there that are mostly for the most part managed by medical oncologists as well. But there certainly is a variety of different jobs, and in some places there'll be overlap. So you work very closely with clinical oncology colleagues. So I think both of them are very valid, very interesting, and sort of really rewarding careers. This is just taken from the curricula, so you don't need to read through all of this, but it's just to show that actually a lot of the curriculum items are actually the same as well. So what do I think of the attractions of medical oncology? To me, the first and foremost, it's how many new treatments are coming through all of the time. So, and I think this is I took this for the first time I did this recruitment webinar about 2 years ago. So this is all of the new drugs that have been licensed just for lung cancer, I think, and that's in 2022. There'll be a few extra ones since then as well. So it's changing all the time. There is lots of scope for research, although it's not essential. If you are interested in research, it is a very research active specialty. And I think it really is, you do look after people at all times in their cancer treatment. So you get some people who you're treating before they have any other cancer treatment. But you're also getting people who are coming towards the end of their cancer journey. And I know for a lot of people in medical oncology, they do find that very rewarding, looking after people towards the end of their life. I think there's lots of research and educational opportunities. You do get to build relationships with patients over time, which I think is a real attraction of it. You get to know people increasingly over years as people are doing better. And I think you do get to work with a lot of different specialties, particularly now with some of the immunotherapy toxicities we're managing. We're starting to have to speak to colleagues that we perhaps wouldn't have been involved with before to manage complex organ toxicity. So I think it is changing. It's getting broader, the amount of treatments we're able to give, and I think that's really exciting. And that's certainly what attracted me to it. And I think it means it is going to carry on being a really rewarding career. So just a bit about what we do on a day-to-day basis. So obviously our clinical job, we're seeing new patients, assessing their fitness, discussing treatment plans with them, and organising that treatment. And obviously, as part of that, prescribing their systemic anti-cancer therapy. So for those of you that don't know what that means, we talk about often chemotherapy, but actually chemotherapy is becoming less and less the main part of our job. So we're giving a much broader range of targeted treatments, immunotherapies, and chemotherapy. Review patients on treatment to see whether they're having side effects, how we manage that, and whether it's working. Managing complications of the treatment, so people that come in acutely with side effects from their treatment. Managing complications of their cancer, so obviously all of the cancer and emergencies that you will have learned as medical students. And we also we do go and review patients. A lot of people do present to hospital with new diagnosis of cancer, and part of our job is to see those and assess what investigations are necessary, what ones are appropriate. And we also do lots of work on, particularly in trial centre, if you work in a big centre, looking at people on clinical trials. But apart from that, there's also lots of non-clinical things that we can do. So lots of scope for audit, creating guidelines, research, which can either be for a PhD or for an MD, but certainly not essential. Going to conferences and meetings, and that's really interesting. There's loads of really interesting conferences all over the country and internationally. Teaching and rota coordinator. I'm not sure how much fun that is, but there's lots of scope for other things. And lots of trainees do take the chance to go out of program either for research or for other activities. So people can do fellowships, including some abroad. There are people that become chief registrars, and there's lots of other sort of leadership and education things as well. This is just a link to our trainee section on the ACP website. So we've just updated this recently. So there is now a section on what training in each deanery is like. So if you're interested in a specific area, you can go to that website, and I'm sure Alison can send the links around afterwards to you. So if you're interested in a certain area, this gives you an idea of what training is like there. Unfortunately, it's not completely filled yet. There are one or two areas we haven't managed to get a summary for yet, but that will be a work in progress. And also we're sort of increasingly seeing that lots of people are coming from abroad, so international medical graduates, and we certainly, the NHS would fall to pieces without them. So we're a very welcome addition to the workforce, but we recognise that it can be challenging moving to a different country and working in a different system. So Dr. Waleed Khalifa, who's one of our trainee committee, who's a representative for our international medical graduates, has put together a really useful summary of some of the things that a new IMG in oncology might face. So some of the way, some advice on how to apply, but also then once you get a job, how to navigate the NHS and the Cancer Drug Fund and all of those other things that you don't get trained about until you expect to do it on the job. So again, we can send the links around afterwards, but that's hopefully really useful for IMGs. Just going through a few tips for the applications. I know we have undergraduates on here, so during medical school, there are undergraduate medical societies that you can be involved with that are oncology specific. Obviously, if you want to do a student selected component or an elective in oncology, that can give you some really good experience to make sure that that's what you want to do, and also to then get some projects going. And I think during your foundation training and internal medicine training, I have put here that you know, it is worth trying to get a rotation in oncology if you can. So ranking jobs that have that highly would be useful. Clearly, it's not an essential part, but it might help because you then have good opportunities to do projects or audits or things like that. But we understand that that's not possible. But what most people can get access to is taster days or clinic exposure. And I think it's also worth noting that whatever job you have, you can always show your commitment to the specialty. I think every specialty now will have some relation to cancer. And so, just an example, last year, one of the people that I marked, they've never had a job in oncology, but they've done a really nice audit on lung cancer in their respiratory medicine rotation, and we marked them very highly because that showed that they had that sort of commitment and thought to try and show that they're committed to oncology. There are teaching and educational resources by various bodies, including the ACP and Notch. And then tips to interview. The ESMO, so that's the European Society of Medical Oncology, have some really good guidelines about managing complications of cancer therapy and managing presentations with acute oncology sort of issues. So that's really worth having a look at because that helps with the clinical station. There's something called Good Clinical Practice run by the National Institute of Health Research, which underpins all clinical research. So getting familiar with that and how research is governed is really useful. And I think it goes without saying, just making sure that you're familiar with your portfolio, that you know what's in it, so that anything that's in it can be discussed at interview. And try asking around locally to see if there are any oncologists that can give you a practice interview, because that would be really helpful. So I think take home messages. One, there's no multiple routes into training, so there's no right way to get there. Each person's journey is individual. As I was trying to highlight in mine, you're not always successful the first time, and if you don't succeed, try and do something that helps. So I went and was fortunate enough to get that fellowship job, and that stood me in good stead for the second application, and then made me a better registrar, I think. It is a research active specialty, so if you're interested, there's loads of scope for that, but it's not compulsory. There are lots of other things that you can do as a valuable career. Lots of people are less than full time, and I will then hand that over to Ben. So thanks for listening, and I will have a look through the chat and see if there's any questions I can answer. So I'll hand over to Ben.
Thanks, Richard. I've tried to address some of the questions that have been going along, but thanks for having me. So I'm Dr. Ben Pickwell-Smith, and I work alongside Richard in Leeds. But part of the reason I was invited today, I have a bit of a dual role. So I've entered the academic training pathway a little bit later on. So I can give an academic trainee perspective as well. I really don't know why I've got a cringy photo of me there. I do apologise, but Richard, you can move on, please. So this is a really common question, and this was coming up in the questions that you all submitted. And the typical question is, do you need a research background? And the answer is absolutely not. And the same for when you become consultants as well. It's not a prerequisite to be a consultant, but it is typically in people's minds as being a career in research and academia. But medical oncologists are expected to contribute to cancer research and clinical trials as principal investigators. But you do learn this in your training pathway, and you don't need these sorts of skills when you're applying. Um, so I've got here at the bottom one of our SIPs, and SIPs stand for capabilities in practice. So at the bottom there, you can see point 18. As part of your training, at the end of your training, you're expected to be able to implement clinical trials of systemic anti-cancer treatments, and skills to lead these trials. Next slide, please. So my pathway is different to Richard's. So this is Keele University, and I didn't do an intercalated degree. Next picture. Then I went to Oxford for foundation. Again, I didn't have any academic part of my pathway. Next slide. I'm choosing really nice, glorious photos here. It's not always sunny in these places. And then I came to Leeds for what was then core medical training. And again, I didn't have any academic component. And prior to my core medical training, I had no idea that I wanted to do oncology, but I was fortunate to get an oncology attachment. And it was that attachment that opened my eyes. And so I didn't really have anything on my CV about oncology, or related to oncology at all up until that job at CMT. Next slide, please. And this relates to quite a few of the questions that we've had in the chat. This part of my story going to the Christie. So I applied, similar to Richard, I applied for clinical and medical oncology numbers, and I got both. But they were both at the Christie, which isn't where I wanted to be because my life, family, friends are all in Yorkshire, Leeds, Hull, York way. So I had a big decision to make. Do I go over and train as a clin-onc or a med-onc at the Christie, or do I do something similar to Richard? So I was a bit confused. But in the end, I took up a med-onc training place at the Christie. Next slide, please. Again, there was no academic component. And then at the end of ST3, I reapplied through the process that many of you will be doing on Oriel. So the national recruitment again, in both medical and clinical oncology. And so the interviews were really funny because they were saying, why medical oncology, why clinical oncology? And I was saying, well, I'm in a training job already, but I'm here to try and get a better score, because the place I want to be is Yorkshire in Leeds. And so I was very fortunate to get offered numbers again. And I stayed in medical oncology, so I kept my number, so I didn't need to go back to ST3. But I think that answers some of your questions there. That if at the end of the common STEM you want to switch specialty, you go through this national recruitment. The benefit of the common STEM is if you did want to switch to clinical oncology, then you get to enter at ST4. But it is repeating this national recruitment. But you'll go into that with a year's worth of experience. So I really did do well second year round, because the answers, it was just so much easier having a year of experience under my belt. So then I come to York, which is a beautiful city, and but now I'm in the Leeds or the West Yorkshire training deanery. Next slide, please. But I've gone through all of this without any academic component, and in 2020, well, the thought process started obviously before then, but I started to increasingly think I'm really interested in the academic side. I love the clinical, but I'd like to learn more skills and gain more experience in academia. So I was very lucky and very fortunate enough to gain a place for a PhD at that's Hull York Medical School. And COVID was very problematic. It got paused a couple of points and I had to return to clinical practice, but I came out with a PhD. And next slide. From then, I've returned to training, but now I'm a clinical lecturer throughout SD5 and SD6, which it gives me 50% of my time is devoted to academia and to working at the university, and the other 50% of my time I'm continuing my training and working clinically. Next slide. So this is the typical academic pathway, of which I am not. So you can, as Richard did, you can do an intercalated BSc, although I'm aware that most of you are qualified doctors. But for the foundation program, you can enter the formal academic foundation program, which gives you dedicated research time and research training. And similarly, you can apply for an academic fellowship throughout your clinical training. So if you press a couple of clicks, Richard. So yeah, I didn't do these formal, but this is where I've entered as a clinical lectureship in ST4, ST5. And who knows what happens next, whether I return back to the NHS or fully, or whether I take up other roles. So academic careers can take different routes, and even if you don't have any formal academic training, medical oncology is a very academic specialty in the trials that we take part in. But there are formal training routes, and the NIHR do fund this. Is possibly slightly outdated in terms of the numbers, but they do fund a number of academic clinical fellowships and clinical lectureships each year. That's the kind of typical training pathway, but there are different routes to gaining academic training. So at the bottom here is one of the Cancer Research UK schemes. So this is a clinical trial fellowship award, and I think there are other different opportunities as well. Next slide, please. So some of my we had some questions about what it's like and our experiences. So these are some of my career highlights. So giving talks and presentations and winning the odd best presentation has been really cool. My researchers took me to New York, so that's Central Park. Next picture. It's not working. This was a conference that I helped. I was on the scientific committee, so I helped organise a national germ cell cancer conference this year, and I got to devise the agenda based around my research interests, which is about inequalities in cancer diagnosis and treatment. So that was an amazing privilege. Next slide. Picture. That's me in ESMO in Madrid, doing presenting some work. Next one. Next picture. And that's me getting my my PhD, which was an awesome day. And in terms of the work-life balance, I should have some clinical highlights there, really. It was a real shame. Next click, Richard. There are lots of work-life balances. So I've got married, haven't had children. Richard's had children. I've run 2 marathons and take part in triathlons. Next picture. That's triathlons. There's a group of us oncologists that do park run every week together. We've become a bit of a park run tourist group. Next picture. Got dog, and final picture. As a group of oncologists that have formed a book club, which I go to. So yes, work is busy, but I have a real life outside of work, which is really, really important. Next slide. So what does the average week look like? Well, this will differ depending on where you are and what rotation you're doing. This was me before doing my academic track. So Monday, and this was when I was on my intensives block, which is a mix of tumor sites that utilize intensive treatment, so sarcoma and germ cell. So on a Monday, I got to go over to the other side of the city in Leeds, where the paediatric oncologists are, and I saw teenage and young adults with cancer. In the afternoon, we had a big grand round. Tuesdays, back at the main side of the city doing ward round, and Tuesday afternoons I did admin. Wednesday morning was a big germ cell clinic, and Wednesday afternoon was time for audit and e-portfolio things and meetings and M&M. Thursday mornings we had the paediatric ward round, and in the afternoon we had different MDTs that I attended and presented at and sometimes led. Friday morning was ward round, and Friday afternoon finished off with germ cell MDT. So it was a really nice, varied week. And it's such a privilege in oncology working with a bigger MDT, and this highlights that. So the surgeons that we worked with and our clinical oncology colleagues and nurse specialists make it a real joy. And it's testament to that Louise is here tonight as well. That close collaboration between our two specialties is fab. In terms of on call, I think I've seen a few questions about on calls. We do non-resident night shifts in Leeds, but we are on site if you're on call until 9 o'clock at night, and at the weekends until 7 or 9, depending. About 1 in 6 weeks, we do a weekend, and then I can't remember the frequency. Maybe 1 in 8 weeks, we are the oncology reg of the week, Monday to Friday, 9 till 5. So I'm not on that this week, actually. Next slide. In terms of a typical timetable in clinical lectureship, so in the academic track, so it's 50-50. So 50% of my week is at the university and the other 50% is in the NHS. You can split it differently, so you can do periods of blocks of months at a time. But for me, my research needs me to kind of keep ticking away at things. So that's the way I've split it this way. In terms of clinics, I do 2 clinics a week, Tuesday, Wednesday morning, and a Wednesday afternoon. I've got some admin time, and we do run a toxicity clinic for patients on immunotherapy that have immunotherapy side effects. And on a Friday, it's ward round and admit, which probably means admin rather than admissions. So sorry for that typo. And then Friday afternoon is MDT and similar on-call work at the minute. Next slide. A few questions have come up about interviews, and Richard and Simon's touched on this. I can't emphasize enough practice, practice, practice. I sat looking at a mirror, which wasn't the best experience for me, but practice with your mum, with friends. If you maybe some of the seniors in your department are putting on some practice as well, but just practice. The first question you'll get asked generally is, why, why this specialty? It's not to say that is a definite question, but you can think about the types of common questions that you're going to get asked. And I sit down and it feels like, oh my goodness, why are you asking me that? And it's a really straightforward question, but in your nerves, it sometimes floors people, and it certainly floors me. So just practice. Be enthusiastic, a smile, and seeming passionate makes a real big difference. Allow yourself 5-minute pause. 5 minutes, no, don't do that. That's far too long. 5-second pause. It'll feel like a lifetime to you, but it doesn't to us interviewers. And it will just allow you to get your thoughts in order. I've put on here about the NIHR good clinical practice. It's worth knowing about because this is in terms of research and academia, and because medical oncology is so grounded in clinical trials, it'd be worth having an awareness of that. Be familiar with your portfolio as well. It's amazing that some people aren't. And there are some resources out there. I don't have shares in this book, but that book I've got a picture of there is absolutely fab, and I've used that over the last decade, and it's still really helpful. Next slide, please. There's lots of educational opportunities when you become a medical oncology registrar or a clinical oncology registrar. There's regular regional and sometimes supra-regional teaching. Often we have local journal clubs. There's some amazing courses out there that you may be able to get funding for. And the Christie run a week-long biological basis of cancer course, and I think they also do a course for the principles of radiotherapy as well. At Leeds as well, we run a similar sort of biological basis of cancer course every week throughout your ST3 year. Often there's fab tumour site studies, specific days at places like the Christie and the Marsden. ESMO, so ESMO stands for the European Society of Medical Oncology. They are an amazing organisation, and we have a big annual congress every year. And they also run these preceptorships, which are 2 to maximum 3 day, essentially crash courses in tumour sites in locations across Europe. There are travel grants available through them, and it's a chance to meet oncology trainees from across Europe, and it's fantastic. The ACP, for which many on here are a part of, run monthly educational webinar series, and they're fantastic. Once a year, we have a UK Oncology Forum, and it's in Harrogate next year, and that's often, I think it's free, and often there's industry events and other conferences. So there's absolutely loads of educational opportunities. Next slide, please. And this may be my final slide because I've talked a lot. Yes, good luck. It's an amazing career, and happy to take any questions.
Yeah, so I've just got here, this is, we can send this round afterwards, but this is just a list of the current regional representatives if you want to ask specific questions about certain regions. And I've put in the chat that if you are struggling to get in touch or struggling to get a project or any research, you can contact one of these representatives, and they might hopefully help you be able to get in touch with somebody. Hopefully you can't hear too much blue in the background.
Thanks, Richard. I think we're going to move on to Satinder if we've hopefully got the slides moving forward.
Yeah, no, fantastic. No, thank you very much. So I'm Satinder Jagdev. I'm a medical oncology consultant from Leeds. And I'm also chair of the Medical Oncology Specialty Advisory Committee at the college. So it's really, thanks, next slide, please. So it's really just to give you some perspective on life as a consultant. And really this slide is just to illustrate again that routes can be different. So my route was different to Ben and Richard's in that following my medical training, I was undecided really of what I wanted to do, and I took a standalone 6-month oncology job, which actually led to me going on to do some research even before I went into a training number. So that was a fantastic experience. But then training in West Yorkshire, and currently working as a consultant at the Leeds Cancer Centre. Yes, thank you. So why go into medical oncology? So really, as I said, I didn't really know what I wanted to do. I was thinking about infectious diseases, and then when I went into that standalone job and got some experience, I actually realised that this was where I wanted to be. So I was really struck by the holistic nature of the work, the fact that we worked very closely with other colleagues, the complex nature of the diagnoses in cancer, and also the management. It really did feel, initially very confusing, but as I started to get to know how we were working, it was, as a junior back then, I think it was really inspiring to see the multidisciplinary approach, and also all of the different modalities that we were using. One of the things that I think is really exciting, and Ben and Richard have said it as well, is that this is a really dynamic, very fast-moving specialty. So really, my job now that I do bears no resemblance to the job that I started off with as a consultant. In the last year or so, there have been multiple new treatments just in my specialty of urology, and really, there's variety, and it's changing all the time. And obviously that comes with some challenges as well, because with new treatments, we have to then think about how do we fit that into the service. But it's all good for the patients. So the team approach, working with the multidisciplinary team, colleagues like Louise and our pathologists, surgeons, radiologists, to look at cancer diagnosis and really dissect out the complexities of the patient that we have in front of us, so that we can make a personalised treatment plan. And in terms of the options, I'll talk a little bit later about those. But there are lots of opportunities to make the job your own, and actually to follow your interests and look at the various things that you want to do. So it's a really exciting career with lots of potential. And as we've just heard, lots of networks and colleagues to link in with. And again, you know, the work-life balance is very good. So I trained for the latter part of my training as a less than full-time trainee, and currently I work less than full-time, but still, you know, with some really fulfilling roles. Thank you. Next slide. So what can you expect? So we've heard a little bit about the process, we've heard about the applications, we've heard about the training, but what's at the end of it? You know, what does life look like as a medical oncologist? And these are some of the components that we've already touched on in Richard and Ben's talk. So as a consultant, we are very much involved, as I mentioned, in the multidisciplinary team. Diagnosis and referrals come in from that. We work in multi-specialty teams and review individual patient cases. And the bulk of our work really is in the outpatient clinic. So whereas, you know, for some of you who have been foundation residents and IMT residents on the oncology wards, you know, things can seem quite difficult and quite dire. The patients are very unwell. Actually, it's really important that you get yourself to some clinics and get yourself to the outpatients, because that's where most of our work occurs, and that's where we see the well patients on treatment. We review patients on clinical trials. We make decisions about their management, and we also then make decisions about you know, bringing in other professionals and other colleagues. So it's really important to see that balance and get yourself to the outpatient clinics. And then obviously the inpatient work makes up another component, and there we see patients with acute complications of their cancer or their treatment, deal with palliative care issues, and on call, the acute work is also a large part of the role. And again, in terms of work-life balance, if you're thinking, well, you know, how would that work with family life? Again, for the majority of consultants in medical and clinical oncology, we're non-resident. And many of us are involved in education. Most of us are involved in training junior residents. And also, of course, clinical governance and research forms a large part of the job. Thank you. Next slide. So there's lots of variety, lots of options in terms of where you can go with your career, in terms of where you can work. So there are options to work in a cancer centre. In some regions, the cancer centre jobs are linked in with cancer units. So you will be based in one, but perhaps doing visiting clinics in the other. In other regions, there are resident medical oncologists in the cancer unit. So they have quite a big practice in the cancer units. There's opportunity to link in with research and academia, teaching and education and training, which I've been very heavily involved in throughout my career as consultant, clinical management, and then working with lots of different external organisations. So the Royal Colleges, so working with specialist societies like the ACP, you know, the European Society of Medical Oncology, working with NHS England, lots of different opportunities to get involved in work outside of your organisation. Thank you. Next slide. So it's really just the beginning. Once you've done all of that training, really you can take it anywhere that you want to go. And this is just, this slide just illustrates some of the opportunities that I've had and some of the projects that I'm still involved in. So very much committed to education and training. I've had the opportunity to work with clinical trial groups, be involved in coaching and mentoring, and in teaching and education. So lots of variety, lots of different aspects to be able to follow. Thank you. Next slide. So one of the questions that we got through was, what are the prospects really for jobs at the end of training? And really, I think with the aging population, with the increase in cancer diagnoses, I don't think we're going to be out of a job anytime soon. There is always going to be a need for oncologists of every flavour. And there are increased, as you can see there, some of the factors are the new and increasing options for systemic anti-cancer therapy. We need people to deliver those, developments in drugs and technologies, the complexities of our aging population, really impact on how we can deliver these drugs and where we can deliver these therapeutic modalities. And we're always striving to improve cancer outcomes and improve treatment access. And clearly we know that across the board, there are limitations with treatment access and differences in cancer outcomes. So it's really important that we address those things. And we have been expanding oncology training posts in both specialties, clinical and medical oncology. And really, there is a recognition that cancer is a priority. So it's been recognised in the new 10-year NHS plan. There is a cancer plan being worked up, and the NHS workforce plan will hopefully address some of those workforce needs. But really, for both specialties, I think there will be a demand. And certainly currently we're seeing that for trainees that are coming to the end of their training, there are vacancies for them to apply to, and also opportunities for people to talk to their organisations before they come out of the end of training, so that people know that they want a job and the type of job they might be looking for. Next slide. So I suppose just some general thoughts in terms of a rewarding and fulfilling career. I think from all of us on the call, you'll have got the flavour that we're all enthusiastic about our specialty. No doubt about it. I think the NHS currently, as it is a very, very challenging environment to work in and to be in. And so you need a career that is going to inspire you, give you that sense of excitement, give you that sense of passion, and really drive you forward, in times that can be difficult. So really thinking about, what do I enjoy? What are the things that stimulate me? What are the things that excite me? And certainly there's plenty of variety and lots of opportunities in oncology in general, and certainly in medical oncology. What are my strengths? So, if you're somebody that likes a person-centered approach, likes to follow patients through their journey from diagnosis through to systemic treatments, and often, towards the end of life as well, that's certainly oncology is for you. You need good communication skills, excellent kind of organizational skills, and certainly be able to get along with your peers. So I put in there, who are my people? I think it's really important to have a look around, speak to oncologists of every flavour, speak to them about their work, speak to them about what drives them also, and just observe how you see them working. Are these the types of people that you want to be around? Are these the types of people that you want as role models? And certainly I've had some fabulous role models in my time, kind of as a trainee, but also some amazing people that I work with currently. So I think that's actually really key to longevity in your career. And then I think the key message from Ben and Richard and Simon in terms of applying for the recruitment and going through the recruitment process is preparation. Look at the information, look at how you can get a taster, look at the opportunities, look at the criteria, pitch your application to that, and also practice. Think about how you want to structure your answers. What are the things that you're going to talk about in your portfolio? Preparation is really key. Next slide. So yeah, go out and have a chat to us, contact us, talk to the oncologists in your area, in your region. Wishing you really all the very best of luck wherever you are in your career. And for more information, there's the ACP website, there is the PRSO website, and also obviously your local oncologists and residents. So very best of luck to you.
Louise has been sitting super patiently listening to us. So Louise, while we get ourselves organised around the questions, was there anything you wanted to pick up or add at this point?
Thank you. Yes. So thank you for showing the slides. So there's a QR code there. If anybody is interested in finding out more about clinical oncology, just scan the QR code and that will take you to the RCR website. And there's my email at the bottom. I'm the Medical Director for Education and Training in Clinical Oncology in the Royal College of Radiologists. So I think in the chat and in the talks there have been quite a little bit about clinical and medical oncology. It's fair to say that the two specialties work sort of side by side, really, to look after the patients with both very holistic specialties and where we deliver cutting edge treatments either with systemic anti-cancer therapy or with radiotherapy. So in clinical oncology we train in radiotherapy and in systemic anti-cancer therapy, as has been said. And very similar to medical oncology, we work in multidisciplinary teams, we meet new patients and we discuss with them, arrive at a treatment plan, we advise on the different options. And we treat patients with radical intent, so curative intent, adjuvant intent, which is those that have had surgery and we're trying to reduce the chances of a recurrence, and palliative intent. And we work in teams within our departments with pharmacists, nurses, radiographers, physicists, etc. We do get taught, so in the ST3 year, you get teaching in both in the Oncology Common STEM, so both medical and clinical oncology get dedicated teaching with the background sciences that will equip you for the future. So there's a lot of support, particularly with clinical oncology. You don't need to be Albert Einstein to be a clinical oncologist. We do get taught physics, but for example, I didn't do physics A level, but we do get taught everything that's clinically relevant to help us to do our jobs and to lay the foundations. So I agree, oncology is a fantastic career, whether you choose clinical or medical oncology. You need to find out what's right for you. Talk to people in your departments. We're a friendly bunch and we'd be really keen to help you understand the specialties. So yeah, thank you very much. There's a QR code and hopefully you've managed to have a little look at the Q&A now. So I'll hand back to Simon. Thank you.
Brilliant. Louise, thank you ever so much. Yeah, I think we've done hopefully quite well. Ben and Richard have been wading in and answering questions as we've gone along. And Louisa, thank you. You've chipped in there as well. There's a few, I know we're tight for time, but there's a couple of quick ones I can pick up from the pre-submitted questions. Because they're relevant and changing. So someone had asked, if they're less than full time, which application cycle should you apply for? All I would say at this point is it's slightly different to previous years. We've started running a second recruitment round because there are more posts and more vacancies, and we've done that this year, and I would predict that will continue. Clinical oncology runs 2 rounds, so hopefully it will fit in better with those of you who are either less than full time or slightly out of sequence. But in common with Richard's comment there, a few months isn't the end of the world if you can get some good experience towards your application. And there's another question in here, which is a lot of theme about how you build your application. I think you've seen some great presentations, but build back from the published information so you can look at how the points are scored and you can see where the points come from. So don't worry about getting 20 papers. Read the crib sheet and see what you need to do, and it's all out there already, so you can build your CV back. Ben, was there anything I think on the chat, we've got through most of them.
I'm just looking now because when I was advancing slides, I didn't want to click anything. So I think Richard's been and Louise has been.
There's an interesting one while we're checking. So Tinder, I'm going to be really mean. There's one here I really like, which is can we think about what impact AI might have on medical oncology? But I think that probably talks to your comment about the way the career changes and how we adapt to the future for all of us, doesn't it? But maybe you'd like to just pick up on that for a second while we get into it. Is that all right?
Yeah, absolutely. I mean, I think it's a really interesting question, isn't it? Particularly for medical oncology, where, I think for radiology, for example, and clinical oncology, you might see more applications. But I guess, it's thinking about what processes do we have that can be automated through AI, and certainly things like, I mean, I guess some of the clerical processes, that could be that can be done across the board. You wonder whether actually for MDT working, there might be some ways of protocolizing patients using AI, and making things more efficient from that point of view. Do I think that, I think on a day-to-day basis, when we've got the patient in front of us, we have to make some really very nuanced clinical decisions. So I think, that's the type of thing that I think, we have the skills to do, as opposed to AI. It could probably learn it, but I think we have the skills to do that. Again, things like perhaps discussions on risk and thinking about risk, for example, in the adjuvant setting, or pre-post operative setting. That's something that perhaps those algorithms might be helpful for. But as I say, I think those are the types of applications that I could see. I don't know whether other people have any other ideas of where AI is already perhaps making an impact.
I think Louise is going to comment. I think the other one is maybe on the research side. I think in terms of sort of drug discovery or just new modalities. I think we're probably just starting to understand what might be automated and where we might get help. But yeah, Louise, I know people in offices not far from me are much better at this than I am, but they tend to be clinical oncologists at the moment.
Thanks. Yeah. So obviously AI is going to play a major role, but there's always going to be the need for medical and clinical oncologists, I think, isn't there? Because people do like that human interaction. But there's a lot of interest, for example, things like contouring in radiotherapy. Can it help us in that? But at the end of the day, you need that human being to help to come to decisions with the patient. And as Satinder says, things like, for example, dictation, that's already been used, MDT, coordination, etc. And then data processing, and we have a lot of information about our patients, and can AI help us to sort of tailor precision medicine, that kind of thing. So basically, yes, agree, as said.
Thank you. I think it also sounds like we all agree, though, that the heart of both our careers is communication with patients, and that is a human interaction, and that's, as you've seen in the presentation, something which it can be incredibly rewarding for all of us. So that's not going anywhere anytime soon, which goes back to the point about how much do you need to be academic in either career. I think that, again, there's a balance for everyone. But brilliant. I think we are slightly over time, and there's been some fantastic questions in the chat. As we said, hopefully we've covered most of the things that have come up. The presentation will be available on the ACP websites, and as Alison said, there'll be some questionnaires coming out after the meeting. We'd love your feedback on what you think was good, what you'd like in the future. And if you've got any burning questions, we're very happy to take those outside of the meeting if we can. You've got those contact details for your friendly resident registrar representatives, and your local TPDs, or actually just any oncologist in a hospital you happen to be working in. Anyone would be delighted to talk to you about getting into a career in oncology. So yeah, essentially none of us bite. Please ask, and most of your questions actually would be resolved quite easily by a chat with someone, I think, and we'd all be happy to do that. So thank you ever so much, everyone, for joining. Thanks to my panelists and for joining and giving fantastic talks, giving up your evening, and hopefully it's been useful. And we wish you all who are listening the best of luck with your applications, and hope to see you in an oncology post not too long from now. Thanks ever so much.